Hi, everybody. It's about 5:15, so we're gonna get started. Can everybody hear me? Okay, just want to make sure sound's working. I guess I'll take that as a yes. Everybody can hear me. Okay. So thank you all for coming to my presentation. Today I'm going to be presenting It's Not You, It's Me, an overview of the management of renal allograft rejection. So for disclosures, I don't have any disclosures. Any brand names that I use throughout the presentation are just for identification purposes only. So for our objectives, our first objective is to identify any risk factors that predispose renal transplant patients to being at a higher risk for rejection, describe the importance of HLA and its role in preventing renal allograft rejection, explain the differences in the pathophysiology of hyperacute, acute, and chronic renal allograft rejection, recognize the signs and symptoms, and identify a pharmacologic regimen for prophylaxis and treatment of rejection. So first, just a question, when you think of renal transplant, what comes to mind? Anybody can shout it out or type it in the text box in the chat. Kidneys, yes. So renal is your kidneys. I know transplant really isn't a topic that a lot of people are really familiar with. So I am going to go a little bit deeper into a background too before we get into the topic of rejection, because you kind of need to understand the whole process of getting a transplant and what happens after in order to understand rejection. So first, some epidemiology. So to date, there's been 18,381 renal transplants in the United States in 2022 this year. So how do we stack up here at Stony Brook? Our renal transplant program began in 1979. Since then, we performed over 2,000 transplants with a one-year graft survival success rate of over 94%. So the average lifespan of a kidney transplant, it depends if you have a deceased donor or a living donor. Living donors, as you can see, do a little bit better. Their transplants do tend to last for a little bit longer. And then the national one-year graft survival rate is also pretty important, because within your first year after your transplant, you are more likely, you're at a higher risk for rejection. And also the rates of living donors do have a higher one-year graft survival rate. So on the last slide, I just told you the one-year graft survival rate. This slide is really telling you the rates of graft failure. So this includes anything such as dialysis, getting another transplant, or death. So on the left, you could see this is for deceased donors, and on the right, you could see this is for living donors. So the bar on the left over here, as you could see, over 50% of patients who received a deceased donor kidney at 10 years have experienced graft failure, versus in living donors, it's lower. It's around like 40 to 30%. Another thing too is it is more common with the deceased donors, and as time increases, you are at a higher risk of graft failure. So over here, this gray or this brown bar is 10 years, and then all the way down here 6 months is this blue. So as time goes on, your percentage for graft failure goes up. But there is some good news. As you could see by these trends, the lines are going down. So over time, we're having less rejection because of better immunosuppression available. So pop quiz before we jump into our drugs. Do any of you know which of the following is not an option for induction immunosuppression? So it actually is C. So I bet you're all probably wondering what induction immunosuppression really is. So on the next slide, now we're going to be talking about induction versus maintenance immunosuppression. So induction immunosuppression is when you're giving high dose short-term immunosuppression before and during your transplant. and it prevents acute rejection versus your maintenance immunosuppression is a low dose, long-term immunosuppression given after transplant, and that prevents acute and chronic rejection. So first we'll talk about induction immunosuppression. So a standard induction regimen, all patients will get corticosteroids plus one of the following antibody agents. So corticosteroids, we all know a lot about corticosteroids. Our options are prednisone and methylprednisolone. So they work by killing off lymphocytes. So that's really how they exert their immunosuppressive activity. And we know that they do have a lot of adverse effects, short and long term, especially at these very high doses. As you can see, the dose is pretty high for patients getting corticosteroids prior to their transplant. And so now we're going to talk about the different antibody agents. So there's lymphocyte depleting and non-lymphocyte depleting. Your lymphocyte depleting agents, those are your rabbit antithymocyte and alemtuzumab. Your non-lymphocyte depleting is basiliximab. So your lymphocyte depleting, they work by eliminating pre-activated lymphocytes. They alter your T cell activation and cytotoxic function, which in turn then leads to a prolonged recovery of T cell count over months. Versus your non-lymphocyte depleting, they don't get rid of T cells, but they really are just inhibiting T cells from working. So just a lot of this is here for you to appreciate. So some things I did want to point out about rabbit antithymocyte globulin. The dosing can be variable, but most of the time it is given for 4 to 7 days. Serum sickness is one of the adverse effects that manifests really as like non-specific symptoms. So patients might experience a fever, arthralgias, rash, hives. They may have swollen lymph nodes. For alemtuzumab, that is a single dose at the time of transplant and then a second dose 24 hours later. Something to note though is that the second dose actually isn't a part of our protocol here at Stony Brook. So patients who get alemtuzumab are getting just 1 dose of it. But both of them, it's really important. I said they are the lymphocyte depleting agents. So they cause a really long duration of lymphocyte depletion. So it's up to 12 months in these patients who get them, which is a really long time to have your immune system really that suppressed for. So now we're going to talk about quickly, since antithymocyte globulin really depletes your immune system, like it wipes it out really well, there are some parameters that you need to pay attention to. So if your white blood cell counts and your platelets are dropping by a lot, you may need to either reduce your dose by 50% or actually hold the dose in order to prevent over immunosuppression. So basiliximab, this is our non-lymphocyte depleting agent. Something I did want to point out is the cost. It is pretty expensive per vial. It's $3,500 and you're getting 2 doses of it. So really your total cost for treatment is $7,000 just for your induction therapy alone. One other thing I did want to point out is that it only is working for 2 to 4 weeks, which is kind of insignificant compared to before where we saw that these agents were acting for 6 to 12 months. So you're probably kind of wondering like when you would pick which one. So this is a study that compared rabbit antithymocyte globulin and basiliximab in patients who were high risk of acute rejection or delayed graft function, who had an allograft from a deceased donor. So it was a prospective randomized international study where they used doses that were standard doses for both of the drugs. And so the primary endpoint, it was a composite endpoint of acute rejection, delayed graft function, graft loss, and death. So the results really showed at 12 months, the composite endpoint incidence was pretty similar, but something that was really important was antithymocyte globulin did have lower incidences of acute rejection. So 15.6 versus 25.5%, and of acute rejection that required treatment with antibodies. So 1.4% versus 8%. So you can see that p-value is pretty significant. And something else to note is that both groups did have similar rates of graft loss, delayed graft function, and death. So something we can conclude is that in our patients who have a higher risk of acute rejection, thymo might be a better option for them. So next, we're going to talk about our maintenance immunosuppression. So maintenance immunosuppression, the regimen consists of a calcineurin inhibitor most of the time is really our backbone for our therapy, or an mTOR inhibitor, or belatacept, plus an anti-metabolite with or without corticosteroids. Depending on your institution, they may or may not use corticosteroids. And it's important to note that immunosuppression begins about 48 hours after you receive your transplant. So this slide is just showing you, I know it looks very overwhelming, but it's really just showing where our immunosuppressive drugs work and how graft damage really occurs. So this green, I guess, blob up here is your antigen presenting cell. And this blue one is your T cell. So the antigen presenting cell presents the donor antigen to the recipient's T cell. So the T cell then sees that antigen and is like, that doesn't belong here. This is foreign, get rid of it. So that causes an upregulation of IL-2, which then causes all of these things down here to happen. And then you then, as a result, end up having T cell proliferation to try to get rid of this antigen, which really then leads to graft damage. So pop quiz, which of the following formulations of tacrolimus are dosed once per day? B. So once a day is Allograft and Invarsus. So technically it's E, but you were partially right with the Allograft. That is also dosed once a day. So now we're going to talk a little bit more about our maintenance immunosuppression. So our calcineurin inhibitors, that's our tacrolimus and our cyclosporins. Cyclosporins rarely used. It's more just here for completeness. Tacrolimus does come in Prograf, Allograft XL, which is an extended release form, and tacrolimus XR is in Varsus. So that's one of our newer agents. So Allograft really isn't used, even though it is once a day and it is an extended release form. When tacrolimus XR, the Invarsus, was being studied, it actually showed not having any peaks within your levels throughout the day. So it kind of something, I want you to kind of think of it as like a long-acting basal insulin that's kind of peakless. That's kind of what Invarsus looked like versus Prograf and Allograft. You did see some peaks in them. So for our mTOR inhibitors, those work by inhibiting T cell proliferation. Their niche is really that they have different adverse effects. So the calcineurin inhibitors, you can see they have a lot of metabolic effects like diabetes, hypertension. They are also nephrotoxic. Your mTOR inhibitors do have dyslipidemia as a potential adverse effect, but they also cause other types of adverse effects more along the lines of like mouth ulcers, pulmonary toxicity. So their niche is really just like in the differing adverse effects. So if you are really concerned, a lot of patients do develop a lot of metabolic effects after transplant because of these drugs. But if you're really concerned about them, you could switch your patients to something like an mTOR inhibitor. And something else to note is they do have antiviral, antifibrotic, and antiproliferative properties as well. So belatacept is our next agent. So it blocks the interaction between antigen presenting cells and T cells. So the niche of belatacept really is that it's renal sparing. Unlike our tacrolimus, which is nephrotoxic. It does have the lack of metabolic adverse effects as well. And it does have improved adherence. Because once you notice, if patients, when they get to the maintenance phase, they're only getting an infusion every 4 weeks. So they're not taking a pill 1 or 2 times a day for the rest of their life when they get belatacept. So it reduces their pill burden. For your anti-metabolites, you have mycophenolate, mofetil, sodium, and azathioprine. So mycophenolate does have a really high risk of these GI effects to the point where it may be intolerable. So azathioprine kind of comes in if you can't tolerate those adverse effects, or if you are uncompliant to the twice daily dosing, because azathioprine is dosed once a day. So this slide is just showing you that over time, we've made a lot of progress. So in 2015, a lot of these newer drugs are drugs that we really use the most and are the best drugs. So for example, tacrolimus XR, that's our Invarsus, came out in 2015. And that's something that we try to get a lot of our patients on if insurance can cover it, because it is really convenient and does work really well. So something I want to just make you all aware of before we start talking about rejection is that transplant really is a balancing act. So you really want to make sure we want to prevent rejection and preserve the kidney function by giving them the immunosuppressive agents. And we do really want to prevent your immune system from recognizing the transplanted kidney. But we also run the risk of, if we overdo it, we can have adverse reactions, because these drugs are pretty, they're really not benign drugs. So it could then lead to a reduced quality of life from these adverse reactions and a potential increased risk for infection, since you are suppressing your immune system. So does anybody can take a stab at what factors may increase your risk of rejection? Yeah, so being older is one of the potential risk factors for rejection. So on this slide, so at the top, the study that I spoke about before with when to pick which induction agent. So if you can remember, they said they tested basiliximab versus anti-thymocyte globulin in patients who were at a high risk. So the patients in the anti-thymocyte globulin, that's where it really plays a role. Basiliximab usually is your first line because it's not as aggressive in terms of attacking your immune system, but the anti-thymocyte globulin is a really good option for our higher risk patients because it does help prevent their risk for rejection. So these ones with the stars, the increased risk of HLA mismatches, the high panel reactive antibody, and the presence of donor-specific antibodies. Those are topics I'm going to discuss in a moment, but before we move on to those, I do want to briefly touch on some of the other ones. So having a younger recipient and an older donor is a higher risk factor. So grafts from donors who are over 65 actually have a higher rate of acute rejection and delayed graft function. Delayed graft function is when you have to get dialysis after a transplant because the kidney still hasn't kicked in yet. So you get dialysis until it starts working. Another risk factor is being of African-American ethnicity. There really isn't a known reason, but it's just been shown in studies that they are at a higher risk. Blood group incompatibility really isn't that big of a problem anymore. Nowadays, we could desensitize our patients with plasmapheresis and immunosuppression prior to a transplant. So that's not something we're super concerned with anymore. Delayed onset of graft function. The real reason is unknown, but there are higher rates of it in deceased donor transplant. Long cold ischemia time, that is it really causes renal tubular cell damage, which then increases your risk of graft failure. Retransplant kind of makes sense because you're exposing yourself to another kidney. And then poor medication adherence really is a big one as well. Every 10% in adherence, or every 10% reduction in adherence is associated with an 8% higher hazard of graft failure and mortality. So now we're going to talk about some of the others. So HLA is human leukocyte antigen. So those are the genes within the major histocompatibility complex, which is known as MHC. That's found on chromosome 6, which I showed over here. It really helps the immune system just tell the difference between self and non-self. So it really plays a big role in the disease and immune defense. So for class 1, and there's 2 different classes, class 1 HLA and class 2 HLA. Class 1 HLA is consistent of HLA-A, B, and C, and it's expressed by all nucleated cells. So they present antigenic peptides to CD8 T cells. Just as a refresher, CD8 T cells are your cytotoxic T cells. That's something to keep in mind going forward through the rest of this presentation. For class 2 HLA, that's your HLA-DR, DQ, and DP. That's expressed on antigen-presenting cells, and those present the antigenic peptides to CD4 T cells, which are your helper T cells. So HLA matching and HLA mismatches. So HLA is determined with a blood test, but it's really more complicated than blood typing. As you can see over here, when you get someone's HLA, like it's not just HLA-A, it's like HLA star 02101, like there's a lot to it that really just makes someone's cells unique. So therefore, we use an HLA mismatch approach rather than an HLA matching approach to maximize the number of patients considered to be a match with a deceased donor. So the more HLA mismatches you have, the higher risk you are at rejecting the organ. So one term to know is sensitization, or being sensitized. So it occurs when someone was exposed to non-self HLA antigens, which then triggers an immune response and then antibodies against the mismatch HLA antigens. So that could be caused by things such as previous transplantation, pregnancy, blood transfusions, and these highly sensitized patients may be more difficult to find a donor. So next, we're going to talk about panel reactive antibody, PRA. So that determines if a patient has any specific HLA antibodies. So they take the patient's blood and they test it against lymphocytes from a panel of about 100 blood donors within the geographic area. Those 100 donors represent the potential HLA makeup within the area. So if the patient's blood doesn't react with any of the donor samples, that's a good thing. That means your patient is not sensitized, so your PRA is 0. But if your patient's blood reacts with 70 out of 100 samples, your PRA is 70, and that means that if a donor were to become available from that pool, the recipient would reject 7 out of the 10 times. So that's a pretty bad thing in the sense that you may have to wait a while until you find a compatible donor. So just in conclusion of this summary, a low PRA is a good thing and a high PRA is a bad thing. So donor-specific antibodies, based on the name, it's really exactly what you think. So they're not good. It's basically antibodies made specifically to the donor's HLA molecules. It predicts antibody-mediated rejection, one type of rejection we'll discuss shortly. So it's tested with a cross-match test before transplant. So once they identify a donor for someone, they test the patient's blood against the lymphocytes from the donor. So what you want is a negative cross-match test. That means that you're not interacting and you don't have any donor-specific antibodies. There are two types of donor-specific antibodies, preformed and de novo. It's pretty much what you would think as well, preformed. They're developed before you get the transplant, and they could cause early acute rejection. De novo is developed after transplant, and they could cause late or chronic rejection. Something to note as well, having one or two donor-specific antibodies doesn't necessarily mean you can't get the kidney, but the more you have of them, the more likely you are to reject. So it's just something that you want to keep in mind when you have a patient who's getting matched to a kidney, something you on the medical team would need to keep in mind and something the patient would probably want to be aware of as well. So before we start talking about the different types of rejection, we have a patient case. We have patient JC, who's a 25-year-old African-American male presenting for a renal transplant. His past medical history, he has CKD on hemodialysis, status post-renal transplant in 2010, complicated by acute antibody-mediated rejection due to being non-compliant to his medications. His donor is a 75-year-old deceased donor. So what are some risk factors he has for rejection, and what induction regimen should we use? Previous transplant rejection is one of them. There's 4. His ethnicity. So the other 2, one of them is just him being a young recipient and having an older donor. And then another one is having poor medication compliance. Does anybody know what induction regimen we should use? So given all of those, the fact that he has a lot of these high risk factors, what induction regimen do you think would be appropriate to give this high risk patient? Anybody? It's just a refresher. There's basiliximab, alemtuzumab, and rabbit antithymocyte globulin is another option. Yes, Dana. Thymo is our best option because he is at such a high risk of rejection. Because remember, thymo depletes your T cell count for up to 12 months. So these are the different types of rejection. We have antibody mediated and T cell mediated. So antibody mediated, there's hyperacute, acute, and chronic. T cell mediated, there's just acute. So first we're going to talk about hyperacute AMR. So hyperacute AMR, it really occurs within the first few minutes after a transplant. I want you to think about it as the same concept as giving someone the wrong blood type. So it's caused by preformed donor-specific antibodies, which activate the membrane attack complex complement system and cause uncontrollable allograft failure. It is pretty rare though, because we do test for those donor-specific antibodies prior to transplant, so it is pretty easily preventable. So now for diagnosis, it's diagnosed usually by the surgeon in the OR. So it's hyperacute. So as soon as the surgeon puts the kidney in, so the kidneys are pink and then they put the kidney into the patient, it becomes mottled and cyanotic. There's no urine output. There's no renal blood flow detected by the renal scan. They also could do a kidney biopsy, and then what they would show is it would show intrarenal coagulopathy, which is where the thrombi are occluding the small arteries and the glomeruli, or renal cortical necrosis. The treatment really is to just take out the graft. If you were to leave the graft in, it could cause potential graft rupture and marked edema. So acute antibody-mediated rejection we'll be talking about next. So acute antibody-mediated rejection, it occurs days to months after a transplant, and it actually is the leading cause of early graft loss. So it has a pretty poor prognosis because as many as 30% of patients who developed acute AMR do experience graft loss. It's most common in recipients with a known donor-specific antibody at the time of transplant. So patients who don't have donor-specific antibodies when they get a transplant is pretty rare, but the incidence once you have like higher levels of donor-specific antibodies, it could be up to 40% within the first month after transplant. So that's pretty significant. So that's why it's really important to do those cross-match testings prior to getting a transplant. So the pathophysiology, I'll take you through it. So the B cell differentiates into plasma cells. So then those plasma cells are what generate the donor-specific antibodies seen here. And then those donor-specific antibodies bind to HLA molecules on the graft endothelium, and then they initiate this cascade. So like I said before, the membrane attack complex, it's pretty much the same thing because they're both antibody mediated. So it leads to activation of complement and recruitment of leukocytes, which then leads to apoptosis and tissue damage, and the end result really is just graft destruction. So acute AMR presentation, actually all the different types of rejection do present very similarly. So this will be the same slide you'll see throughout the presentation. So however they present, sometimes they do present asymptomatic, and it's found kind of like incidentally when they come into the clinic. They may have that rise of serum creatinine. They may notice they have anuria or oliguria, higher blood pressures. Really, these other signs and symptoms are pretty non-specific as well. The only one I guess that is kind of specific is having pain or tenderness over the kidney transplant site itself. So for the diagnosis, having a renal allograft biopsy really is key to diagnosing. So that'll help determine your etiology, whether it's antibody mediated or T-cell mediated, and help you detect any irreversible kidney damage. So the way we diagnose once we get the biopsy is the Banff criteria. So it requires all three of these over here. So you do need to have histologic evidence of tissue injury, evidence of current or recent antibody interaction with the endothelium, and the presence of donor-specific antibodies. So also acute AMR, like I said, is the leading cause of early graft loss. So therefore, early aggressive treatment is really important in these patients who develop it. So for our treatment, there's the plasmapheresis, IVIG, and rituximab. So plasmapheresis, you usually get 3 to 5 sessions of it, and then you'll receive IVIG or rituximab after each of these sessions. So IVIG is usually ordered as 2 grams per kilogram, infused slowly over 12 to 24 hours. And rituximab, the dosing is there for you to appreciate as well. This is a lot, but I just do want to point out the mechanism, how they all work. So for plasmapheresis is really taking out those donor-specific antibodies, so it's reducing the levels of them. It is able to reverse some cases as well alone. IVIG has immunomodulatory effects, so it causes antibody clearance, neutralization, inhibits that complement cascade. And then rituximab, that is a monoclonal antibody against CD20 antigens that are found on B cells. And if you can think back, the B cells are what turn into plasma cells that make those donor-specific antibodies. So you're really, if you give rituximab, you're really stopping it at the source. So this is our power plan for what it looks like when providers are ordering it here at Stony Brook. So they pre-medicate with the IVIG. They pre-medicate with diphenhydramine and acetaminophen. There's also PRN medications for the potential reactions. So bortezomib, this is something that is used as a rescue therapy for patients who don't respond to these other agents, the plasmapheresis, IVIG, rituximab. So it works, it's a proteasome inhibitor, and it causes plasma cell apoptosis. So that's pretty significant. It does have significant adverse effects though, such as peripheral neuropathy, fatigue, and weakness. So something, there were some case series, actually, these two down here. They know that bortezomib alone is doesn't really have much of an effect, but there's mixed results in combination with plasmapheresis and IVIG. So this first case series really showed reduction in plasma cell infiltration, stabilization of the graft, which seemed pretty promising. But then another case series actually showed adverse effects of bortezomib being intolerable. So now we're going to talk about chronic antibody-mediated rejection, which is something we really don't know a lot about. We know that it's chronic, it occurs over time, it's a gradual loss of function, but we really don't have any confirmed causes, pathophysiology, and then diagnosis. It's pretty difficult to diagnose. So it's thought to be due to medication non-adherence or inadequate immunosuppression, which kind of makes sense because if that's happening, your immune system is constantly kind of turned on. So it's slowly damaging the transplanted kidney over time a little bit, like every day. Overall, it does cause an estimated 5,000 allografts per year are lost to chronic AMR. So like I said, the pathophysiology is pretty much unknown, but since it's AMR, we do know that this does play a role in it somehow as well. Presentation, like I said, very similar to acute, same exact things, asymptomatic or maybe found incidentally with the rise of serum creatinine or these non-specific symptoms and potentially producing little to no urine. So chronic AMR treatment, it's often not reversible once you develop it because chronic AMR, the damage has been going on for so long, it's essentially irreversible. So really, when you think about it, the kidney can't regenerate what it's already lost. So it is unresponsive to a lot of current therapies, and there really isn't any therapy that's FDA approved for it. Patients are commonly treated with combination therapies. So we're really just throwing the kitchen sink at these patients. It is really difficult for us to know what works and what doesn't because we're giving them so many combination therapies. But there is this large unmet clinical need. So that proves that it is a new area of research that is developing. So in terms of research, one of the things they're looking into for the treatment of chronic AMR is tocilizumab. It's FDA approved for the treatment of RA and juvenile idiopathic arthritis. It's an IL-6 antagonist, which IL-6 regulates inflammation and development, maturation, activation of T cells, B cells, and plasma cells, which I've been speaking about throughout this entire presentation. When IL-6 interacts with the receptor, that's critical for the allo antibody generation in the animal models. So the thought is that by blocking this interaction, the opposite's going to occur. So you're going to have reduction in these allo antibodies and inhibit the plasma cell anti-HLA antibody production. So here's the trial. It's a single center open label case study at Cedars-Sinai Medical Center. So they were providing tocilizumab as rescue therapy for patients with donor-specific antibodies who had chronic rejection and previously failed the standard of care treatment with IVIG, rituximab, and plasmapheresis. So it was only 36 patients because it is a case study, so that is something to keep in mind. But the results were pretty promising. It did show that the patients who got tocilizumab had graft survival rates of 80% at 6 years and patient survival rates of 91% also at 6 years. It also did show significant reductions in donor-specific antibodies and stabilization of renal function at 2 years. So this really does show that tocilizumab may be a potential emerging treatment for chronic AMR. So now our last type of rejection we're going to talk about is acute T-cell mediated rejection. So a little background on it. It typically occurs during the first year post-transplant, and it is pretty rare as your time increases since you had your transplant. Over the last 2 decades, the impact of T-cell mediated rejection on graft survival has decreased because we do have these new immunosuppressive agents that are better, like I had mentioned before. And TCMR is pretty responsive to treatment as well. So a lot of studies nowadays and research is really focusing on AMR and donor-specific antibodies and long-term graft survival. But it is something still important to know because we haven't completely eradicated TCMR, so patients still are presenting with it. So this slide is just an overview of the pathophysiology. So you have the direct pathway and the indirect pathway. So we'll start off with the direct pathway. You have the antigen presenting cell of the graft that has class 1 MHC molecules visualized over here, recognized by the CD8 T cells, and class 2 MHC molecules recognized by the CD4 T cells. Remember, your CD8 T cells are your cytotoxic, and CD4 are your helper T cells. So following down the CD8 T cells, they notice this, and then they take it as a warning to go around, and then they start to kill all the cells that have that foreign MHC molecule on it. So that causes inflammation of the endothelium here in the renal blood vessel. So that inflammation then gets out of control, and you have graft ischemia due to a lack of blood flow to the area. So the CD8 cells, they continue on to cause damage, and they go to the renal tubule, where then they recognize the MHC complex here, and then they begin to kill these cells here. So basically your CD8 T cells are cytotoxic. So as soon as they see something foreign, they're going to kill it right away. Now, on the contrary, your CD4 T cells, they are kind of the ones that get other people to do the dirty work for them. So they will recruit the activated macrophages to then go in and destroy the cells so the kidney can no longer function. So like I had said, the CD8 cells, those are really the ones that get the job done themselves, versus CD4, they kind of get other people to do it for them, which is your activated macrophages. So now our indirect pathway. So here we have the graft cells and the recipient's antigen presenting cell. So the recipient's antigen presenting cell will see these graft cells and they'll realize that they're foreign. So they're going to chew one of them up and they're going to break up all the molecules inside and put them on their MHC. So then when the CD4 cells are going around in the body, they see it and then they're like, we have an invader, we have to get rid of it. So they undergo that same process where they go in and then they kill all the cells within the kidney, which then in turn leads to graft dysfunction and rejection. Presentation, like I had said, all of the different types of rejection do have the same presentation, can be asymptomatic, detected via lab values with their creatinine, or it could be just really generalized symptoms. So again, renal biopsy is key for diagnosis. So same thing as before, to determine the etiology, detect irreversible kidney damage, but also in T-cell mediated rejection to grade the severity of the rejection. So the way you diagnose and stage it is the Banff criteria. So a higher number indicates more severe disease. So for class 1A and 1B, you notice they're pretty similar. The only difference is 1A is moderate and 1B is severe tubulitis. So tubulitis is when you have inflammatory cells between the tubular epithelial cells, which can be due to many things such as infection. Class 2A and 2B is where you have intimal arteritis, which is inflammatory cells being in the intima, which is actually a sign of pretty poor prognosis. And then class 3, you have transmural arteritis. So that's where it's going through the entire wall. And then, and or fibrinoid necrosis, which is really irreversible, uncontrolled cell death, where the antigen antibody complex are developed or deposited into the walls of the blood vessels. And something to keep in mind really is that the grade guides your treatment. So that's really important. So if they diagnose you as class 1A, you could treat it with methylprednisolone alone. If you're diagnosed with 2B, you could be treated with methylprednisolone if you have mild graft dysfunction. And then you could get RATG, which is our anti-thymocyte globulin, if you have severe graft dysfunction. But once you hit class 2 and 3, you're automatically going to be eligible for the anti-thymocyte globulin. So this slide is nothing new. It's just repeated information about methylprednisolone for your reference. So the mechanism of action, the sequestration of T lymphocytes, and the adverse effects here as well. So for the treatment with anti-thymocyte globulin, some things I did want to point out is here at Stony Brook, this is what we use to dose it, 2.5 milligrams per kilogram for 3 days. Has to be administered IV using a central line and a filter. And then pre-medications, you need to pre-medicate with methylprednisolone, acetaminophen, and diphenhydramine. And so finally, our patient JC, he's coming back to the clinic 2 months after his transplant. He says he's experiencing pain over his transplanted kidney site and he's been feeling under the weather. His vital signs, his blood pressure is 160/91. His serum creatinine is 2.4. And then he's admitted to Stony Brook and they do a biopsy of his transplanted kidney. And it shows 30% interstitial inflammation with moderate tubulitis. And they diagnose him with grade 1A T-cell mediated rejection. So how do you think that we should treat our patient JC? What should we give him? We have 2 options, steroids or anti-thymocyte globulin. And he has grade 1A. Yep, methylpred is how we should treat him because he's grade 1A. So he doesn't necessarily need to get the RA teaching. So in conclusion, some patients are at an increased risk of rejection than others, depending on if they have modifiable or non-modifiable risk factors. It's important to perform HLA cross-matching before a transplant to lower the chances of rejection. Newer and more effective maintenance immunosuppressive therapy has led to a reduction in cases of rejection. And then the two types are antibody-mediated and T-cell mediated. And then acute antibody-mediated is the leading cause of early graft loss. And I just want to say thank you to Diane for reviewing my content. And thank you all for your attention. Does anybody have any questions? Okay, so if nobody has any questions, I just want to say thank you all again for coming. I'll be emailing you all the post-assessment questions, and then you'll just send the responses back to me and I'll send you the code so you could get an hour of credit for attending my CE. So thank you all so much, and I hope you all have a great rest of your day.